Okay, so assessment of visual functions. So case history. The case history can provide significant information about visual functions. Symptom of blurred vision or an inability to see well enough for certain tasks, such as reading the whiteboard, school books or newspaper, watching TV, driving, etc., or suggest reduced vision due to ametropia or ocular disease. Okay. Distant visual acuity. Distant visual acuity is a measure of the patient's ability to resolve fine details. It is the most commonly used measure of visual function made by clinicians. VA is used to assess the adequacy of spectacle corrections and as a key indicator of ocular health. VA is also used to assess a person's fitness to drive or enter into some professions, such as the police force, and to enable registration as a partially sighted or blind person. The need to measure VA accurately is obvious. So there are three principal measures of VA. One is the unaided VA, often called visions. Two, habitual VA with the patient's own spectacles. And three is optimal VA with the best refractive correction. That is after subjective refraction. VA with the retinoscopy result is also often recorded. Either vision and or habitual VA should be measured immediately after the case history for legal reasons to document the VA level prior to your examinations. Habitual and optimal distance VA are routine measurements. Measuring distance unaided VA vision is optional and should be measured with patients who do not wear spectacles, have lost or broken their spectacles so that you cannot measure habitual VA. Do not wear spectacles for some distance viewing tasks. This information must therefore be obtained in the case history. Require the information for a report. Wear their glasses all the time for distance and yet you suspect they may not need to do so. Does the young low hyperope need to wear spectacles for distant tasks? All right. So you got advantages and disadvantages. So logMAR visual acuity charts are widely recognized as providing the most reliable and discriminative VA measurements and are standard for clinicians' research or clinical trials for ophthalmic device or drugs. All right, so you got the procedure here. So ensure that the chart is at the appropriate distance and is calibrated correctly. Leave the room light on and illuminate the chart. If you are going to measure both vision and habitual VA, measure vision first to avoid memorizations. To measure vision, ask the patient to remove any spectacles. To measure habitual visual acuity, ask patient to put their distance vision spectacles on. Measure the visual acuity of the poorer eye first. If a poor eye is known from previous records or from the case history, to avoid a patient memorizing the letters, screen with the better eye and giving a false visual acuity with the poor eye. Otherwise, measure VA in the right eye first. Explain what measurement you are about to take. This can be simple as, now we shall find out what you can see in the distance. Instruct the patient, please cover your left or right eye with the palm of your hand. or hand or this occluder. If using the patient's hand, make sure that the palm is being used, as otherwise the patient may be able to peek through their fingers. Some clinicians prefer to hold the occluder over the patient's eye themselves to ensure it is properly occluded. Ask the patient, please read the smallest line that you can see on the chart. Continually monitor the patient's facial expression and head positions. Do not permit the patient to screw their eyes up or look around the occluder or through their fingers. A hyperopic shift is common in older patients, and some PAL or varifocal wearer adapts to their change by habitually raising their chin to improve distance vision by viewing through the additional plus through the intermediate sections of the lens. This can be seen when assessing habitual VA, as these varifocal wearers all raise their chin during measurements to improve VA. VA should be measured through the distance portion of the lens. You should make a mental note that these patients will likely require additional plus or less minus power in their distance corrections. Once the patient has reached that they believe are the smallest letters they can see, they should be pushed to determine whether they can see any more. Use prompts such as, can you see any letters on the next line, or have a guess. It doesn't matter if you get any wrong. Some patients are more cautious than others and only indicate those letters that they can see easily and clearly. Unless you push patients to guess, you should obtain different VA results depending on how cautious your patient is. Ideally, you should stop pushing patients to read more if they make four or more mistakes on a line of 5 letters. If the patients cannot see the largest letters on the chart, ask them to move closer to the letter until 2 or 3 lines can be seen, or use a printed panel chart at a reduced distance. The distance at which this occurs should be noted. This can be more accurate assessment than determining the position the patients can count fingers. If the patients cannot see the letters even at the closest test distance, use the following test sequence. Stop at the level at which the patients can accurately respond. Hand movement, shortcut HM at Y centimeter. So the patient can see a hand movement from a certain distance. Some computerized VA tests can provide accurate measurements down to the hand movement level. B. Light perceptions. The patients can report which directions light is coming from when you hold a pen light about 50 centimeters away. Ask the patients to point in light and note the area of the field in which the patient has light perceptions. Light perception, and then see light perception. The patient can see the light, but not where it's coming from. If they cannot see light, the vision is recorded as no light perception, or NLP. 11. Record vision, or VA. Repeat measurement for the other eyes and binocularly.